Trials Unit at the University of York. This is the Research Room. Hello.
Hello.
Welcome back to the Research Room with me, Lucy Ather.
And me, Janine Healy.
And today in the Research Room, we are joined by Professor Alex Smith and Professor Debra Howell. And you're going to tell us all about your very, very interesting blood cancer research network project. So welcome to the Research Room.
Thank you.
So just to get us started, could you introduce yourselves for us, please?
Yeah, my name's Alex Smith. I work here at the University of York in the Epidemiology and Cancer Statistics group, and I'm a cancer epidemiologist.
My name is Debra Howell, and I work in the Epidemiology and Cancer Statistics group as well. And I've worked alongside Alex for the past 27 years or so. And together we work on the Haematological Malignancy Research Network.
Fantastic. Thank you so much for joining us. I'm really looking forward to learning all about your project. So it's not a trial like we normally do, is it? It's a research network, a database. So really excited to learn about all of that. But just to start us off, so what is the name of your project? I know you just said it and I've forgotten it already. Was it? So it's HMRN, isn't it? But what does that stand for?
It's the Haematological Malignancy Research Network.
Great. And haematological, that's blood.
Yes. And
so is that cancer, the malignancy bit?
Yeah.
Research network. Okay, that all makes sense.
And I suppose we usually do a bit where we rate the name, but we can't do that. Really?
Yeah, we can't. It's not really fair to rate.
It's not like a trial name.
No, it's not like a trial
So we
name.
won't do that.
But it does just says what it is.
And the reason why we have network is because it's not just here, us at the University of York. It incorporates the whole clinical network for haematology in our region.
I see.
So that's why we use the word network.
Yeah. Oh, right. So so it's not just York. It's the whole sort of
we
Yorkshire,
cover all of Yorkshire apart from South Yorkshire.
Ah, great.
So there's
Why? What did
South Yorkshire just have a different... Yeah, I'm from South Yorkshire, so I've got nothing against South Yorkshire. They just have a different organisation for the delivery of haematological cancers there compared to North West and East Yorkshire. So this region here have been a network for over 30 years. They've always worked very closely. And there's 14 hospitals that treat all the patients diagnosed. But importantly, all those patients at the 14 hospitals are diagnosed by one centralised laboratory, the Haematological Malignancy Diagnostic Service, that's based at St James's Hospital in Leeds.
Right.
And that's why we can do the project, because they do all the diagnostics for the region.
Right. Okay.
So that's why it's a network,
And it's all kept in a database, isn't it?
Yes. So what happens is that we get about 2,500 patients diagnosed with a haematological cancer in the network each year. And every week we ascertain who's actually been diagnosed the week before. So we get about 30 to 40 new patients. And we work very closely with the NHS. We work very closely with HMDS. And based on their diagnostic database, we then collect pseudonymised data. And which then we do all the clinical data collection. So we have a team of research nurses that visit each of the 14 hospitals. They used to visit, but now it's all done remotely, electronically since COVID. And they collect a lot of the clinical data. So patients' demographics, what stage of disease they are and how they're managed. And then we also do lots of data linkages to national data sources. And then there's also the patient aspect, which I'll hand over to Debs to explain.
Gosh, I interrupted you. You were going to say something.
Oh, it's okay. I was just, when we were talking about the geographical region of HMRN, I think you mentioned Yorkshire, but we also cover parts of Humberside.
East Yorkshire. It's
East
not Humberside.
Well,
it's Yorkshire and Humber. Humberside
Yorkshire
doesn't exist
Humber.
anymore.
Yeah. So that means we go as far as Hull and then over the Humber to Grimsby and Scunthorpe as well.
So a bit North Links.
Yeah, so there's that extra. And so the population as a whole is 4 million people.
Wow.
The catchment.
Yeah, the catchment population.
Oh, wow.
And within that area, there are 2,500 more or less new diagnoses each year.
Wow.
So they just add on to
That's a
our
lot.
study on a week-by-week basis.
Right.
So-
So whenever anyone's diagnosed with a a blood cancer in that area,
Yeah.
they're added to your database.
Yes.
Exactly, yeah. So now we've got about...
Nearly 60,000
Wow.
patients on the database.
Yeah.
That's a
Yeah,
lot.
because we've been going since 2004.
Yeah. So,
That's a long
and
time, isn't it? That.
Yeah.
yeah, so it's over 20 years, and each and every one of those patients have information collected from the medical records by the team of research
Right.
nurses. So we end up having the full pathway, right from diagnosis and for the information that's collected about disease stage, for example, and performance status at that time. And then we log all the treatments all the way through the patient's pathway.
Ah, right.
So we get these. Some of them are simple, but a lot of them are really, really complicated, aren't we? Aren't they? The pathways themselves. Some people are just observed, and others have treatment after treatment after treatment.
So when you say pathway, is that the care that they're getting?
Yeah. So it's whatever happens to them from the point of diagnosis through to the start of treatment and the response to treatment, and then the follow up and the next treatment if they need another.
So you've got it sounds like you've got a really detailed picture of exactly from when they're diagnosed, exactly the treatment they get, and I guess would you see how they respond to the treatment as well and things like that?
Yeah, exactly. And we have that on every single one of the nearly 60,000 patients, but we also have the link into other data sources, don't we?
Yeah, so we link to national data. So we link to something called hospital episode statistics, which is the national reimbursement database for hospitals. But we can use those data because they record if a patient's had an outpatient appointment, if they've been an inpatient. So we can look at their hospital activity and what procedures they've had.
Oh, so you can see not just that specific cancer treatment, you can see everything they've sort of ever had.
Yeah. So we can use those sort of data to see why a patient may have developed a haematological cancer in the first place.
Oh, yeah, of course.
Because there's certain diseases that increases a patient's risk of getting a haematological cancer. So we can look at that. And what we can also do, which is really important, is look at the long-term effects of treatment. So some of the therapies may cause cardiovascular issues later in life. So we can actually see what happens to the patients longer term and if they have an increased risk of getting the long-term side effects.
So you can follow them even after they've finished their cancer treatment. You can then see what else happens to them.
Yeah.
So when you say hematology, I can't say it, sorry.
It's all right.
Hematology.
Say blood cancer.
Yeah, there you go. Yeah.
When you say blood cancers, what blood cancers are there? Because I know of leukemia.
Well, so this is one of the reasons we set up the project. So in fact, people tend to think of blood cancers. You'll have heard of leukemia, myeloma, and possibly lymphoma.
Yeah.
And that's split to Hodgkin's and non-Hodgkin's lymphoma. But actually, it's a lot more complicated than that. There's over 100 different diagnoses of blood cancers.
Yeah, wow, I had no idea there was that many. Like you say, I'd heard of leukemia. I've maybe heard of the other two that you mentioned, but not 100. Wow.
Yeah, there's over 100 different types. And that's why we set the project up, because they're so complicated. Back at the beginning of the century, all you knew about blood cancers at a population level. So what we talk about population, we talk about everyone who's diagnosed, was whether, say, they had leukemia. But actually, you can have something like acute myeloid leukemia, which is very aggressive. Outcomes might not be so good. You have to be treated intensively. Or you could have something like chronic lymphocytic leukemia, which 80% of patients don't ever need any treatment. They're just observed. And survival can be very good. So by lumping them all as leukemia, there was no meaningful data. So they didn't even know in the country how many patients there were with certain subtypes, how people were doing, how people were treated. And because of our network, the NHS network, we could actually do a population-based study here because we could capture everyone because everyone had to be diagnosed in Leeds. And what's really important about the diagnostic lab in Leeds is that they're the state of the art. They do all the different laboratory tests to diagnose a haematological cancer. So usually there's lots of different tests. So you'd be looking at the morphology, so you'd be looking down the microscope, but you'll also be doing things like flow cytometry. And more recently, you've been doing lots of mutational analyses to actually say what diagnosis this is. And it's all those pieces of information that form the actual type of leukemia it is.
Yeah.
And HMDS, they were actually the world leaders in putting everything under one roof and having an integrated laboratory. And what's really good now in the UK, they've moved to that model. So each region now has its own HMDS.
Oh, right.
So it's making sure that all the patients are diagnosed correctly.
Yeah. And sort of standardising it. Across
and accurately, because they are complex. Yeah. So that's one of the reasons why we set up the project, was that there was just no accurate data.
Yeah.
Oh, right. It's good. It's It's so eventually it'll go. Everybody will.
So there's always been cancer registration nationally, where every patient with a cancer, not just blood cancers, registered. Because it's part of public health. They need to know. So the national cancer registrations are still recording everyone in the region. It's just that we can do additional data linkages and really collect really granular, detailed data on them.
I see.
So, because what you might be looking at survival, but what you really want to know is how patients were treated and how they responded to that treatment. So we can have a look and say, if they got this chemotherapy, this is how they did. So you really want the treatment data alongside it.
So you're saying the other registries, they just look at survival data, basically?
So national data's really improved since 2012. We actually contributed to trying to improve the national registration because they learned from what we did.
Yeah.
So there was some of I was on the committee with some of the haematologists, and so the national data is a lot better, and everything's now. So you get all the different types of leukemia, say nationally, but just because we've been going for 20 years, we've got the long-term data. And also because we are an academic research unit, we do quite obviously a lot of research on those data.
Yeah.
You use your data, don't you?
Yeah.
We can look at things as well, like the impact of new treatments. Because the data goes back so long in time that a new treatment might be introduced, and that might be a result of a clinical trial. So it's specific to maybe younger and fitter people. But because we register everyone, we can look at the impact of new treatment across the general population, including people who are older and wouldn't be in a trial necessarily. So I think that's one of the ways that we can kind of show impact as well, isn't it? That we can actually describe what happens with the new treatments.
That sounds really important.
Yeah, because sometimes you might have a trial that looks really promising, but when it's actually given to patients, and that's what they call real-world data, the trial might not show such a great effect. Or conversely, you might actually get a better effect than you saw in the trials. So it's really important to know how real patients are responding to that
sort of see
clinical
how it
trial
affects
drug.
people in the real world and how it affects all the data that you can get.
Yeah.
So could you tell us who sort of uses this data? So you've got brilliant data set, and then is it that researchers can look at that and do sort of studies from it?
So we work really closely with the clinicians to answer research questions and the laboratory people. So a lot of our research is they'll observe something clinically, or they want us to look at something. So they'll say, "Can we look at this?" And we work very collaboratively. So we do basically a lot of in-house research. There is possibility to collaborate with us as well. Another example how we've used our data is when a new drug needs to be approved by NICE, the pharmaceutical companies have to put a submission, and they've got to show that their new drug is better than what's standard of care in the NHS.
Okay.
So we then also do joint working with pharma, where we can show how patients with a certain line of treatment or characteristics are doing with standard care of treatment. And they can then benchmark it and then use that perhaps as evidence to try and get the drug approved for use in the NHS.
Okay, yeah.
And another use is to make sure that the different hospitals in the region are treating people in the same way according to the national guidelines. So kind of as an audit.
We do quite a lot of audit work with the clinical network.
Because you'll be able to see the kind of survival rates, but also other things and it's just, at each location.
Yeah, because cancer treatment tends to be very regulated about what patients can get. It's got to be approved by NICE. So it's making sure that all the patients are getting the approved treatments and there's no difference in the network hospitals, the way patients are treated.
And we can, if we do find any differences, we can use the data to kind of explain it as well, because it might be that Leeds is doing more transplants, for example, but actually they're a hospital that really sick people get referred to. So they're likely to have a higher rate of transplants and things like that.
Yeah.
So we can use it to look at things like that.
Yeah. I've got written down here that there was a really good example with a myeloma paper.
That's
I don't know
right.
if we could talk about that.
Yeah, we looked at all of about 1,900 patients and how they were treated at first line over the last 20 years. And we looked at how the chemotherapy had changed over time. And then we looked at how patients were doing and survival. So the median survival when we first looked, so when we first started the project, was 2.4 years.
Oh, wow.
And then the patients who have been more recently treated, it's doubled to 4 years.
Oh, great.
So that was a really nice example where we could show that all the trial data, all the approvals actually really did impact on patients. And one thing that was particularly nice was that the biggest impact was in older patients.
Oh, right, yeah.
So patients over 70, 80 actually they couldn't tolerate the more intensive chemotherapies, but actually less intense treatments have come on, and it showed how well they'd responded to them.
Oh, that's good.
Yeah. Oh, so that's really nice. Yeah, you can use it to really see how treatments are working, and then that must be nice when you see something like that really works. You're like,
yeah. I think haematology is one of probably the fastest specialities in the development of new drugs. So it's really nice that we can benchmark and show improvement with those new treatments.
Yeah,
it is. Yeah, brilliant. So, how did you both come to work in this area of research then? Because you apparently, how many years did you say you've been together?
27.
Oh, it sounds like you're a couple.
Working together.
Working together.
So we were originally, so I was doing my PhD at the University of Leeds, and the unit was originally in Leeds. And then you came to do your PhD.
Yeah.
Very different areas. So I'm an epidemiologist. Debs is a qualitative researcher.
So I should have said that in the outset, actually. But so Alex does the epidemiology, and I'm a qualitative researcher. So, and I'm also the PPI lead for the group as well. So I do a lot of work with patients and the public. So I think I've got the best job in the group, really, because I'm the person that gets to go out and talk to the patients and the caregivers and things.
So when we were in Leeds, the unit focused on etiology, why patients developed blood cancers.
Right, okay.
So they did a lot of case control studies, trying to figure out why patients developed them. So we were doing that work. And then because we were at Leeds, the head of the diagnostic lab, HMDS, had this idea of setting up a registry. And because we were an epidemiology unit, he came to see us, and it was Eve Roman who headed the group, to talk about whether we could set up this register.
Right, okay.
So that's how we ended up. And then we moved to York, which actually made it easier setting up the register in a way, because we were more part of we weren't just at Leeds, we're moving into the other part of Yorkshire. So we had
Leeds
more
dominated.
reach. Yeah. So that's how we ended up getting into setting up the study.
Yeah.
And I think that because, as Alex said, there's 100 different subtypes, so and the treatments change really quickly. So it's a really interesting field to work in, because there's always something new to be thinking about, and a new treatment. And from my perspective, the patient experiences are really different according to what diagnosis people have. So having leukemia is totally different to having lymphoma, to having myeloma, and then they differ according to whether they're acute or chronic versions. So, so there's
acute or chronic. It always confuses me that. What's the difference between acute and chronic?
So for example, if you had acute myeloid leukemia, it's really aggressive and really severe, and the symptoms come on really quickly, and you need treating within days if you're going to survive. And the treatment's quite toxic and intensive. And you can be in hospital for the first 6 weeks, 2 months, something like that, having this chemotherapy. Whereas the chronic disease variant, so like Alex mentioned before, you might get chronic lymphocytic leukemia, and you're diagnosed, and then you're just observed for the rest of your life, and you don't need any treatment at all. And your life expectancy can be is very good compared to acute leukemia.
I see that.
So even but So even if you're talking about leukemia, there's this massive sort of spectrum of different experiences along the pathway. So yeah, there's always lots of different things to look at.
Yeah. It's definitely complicated.
It is,
I think
So
it's
we-
sorry, just to say,
Yeah.
the more and more they understand about the biology of the diseases, the more and more subtypes are recognised. So when we first started, there were probably about 50, 60 diagnoses. And every, I think, 5 years, the World Health Organization, they put a panel of experts together to look at all the diagnoses. And then because they might understand more about the biology, they might recognise a newer subtype. And that's really important, the biology, because the treatments can be targeted.
Yeah.
So there's more, the greater the understanding, it's just going to increase the numbers of different types of diagnoses.
But yet they're all under the umbrella of blood cancer.
Yeah.
It's a big umbrella, isn't it?
It is.
Yeah.
Yeah.
But were you involved, when you did your PhD, was it a biology one or no?
That was epidemiology.
Oh, yes.
Yeah.
Explain what epidemiology is quickly.
So it just really means who, where and what. So basically you're describing who has the disease, where they are perhaps geographically and why they've got the disease. So,
Is it sort of looking at it like at a population level?
Yeah.
That's what I always think.
Yeah,
of
it is,
epidemiology.
exactly. So you're looking at the whole population.
Yeah.
And did I read somewhere that the population you've got in your database is got sort of, it's the same demographics as the rest of the UK?
Yeah, that's right. So our age and sex distribution of the region is the same as the rest of the UK, which is really important. So it means that our findings can be generalised to the rest of the
really
UK.
Useful, yeah.
So one of the first things we actually did was even say what the disease incidence of these subtypes were, which no one else had done, which might sound quite boring, but actually you do need to know how many people in the population are affected by these diseases to make policy decisions, to know how many people are treating. So we can scale up our findings to the whole of the UK. And in fact, some of our findings have also been used in other countries, such as Canada, the Nordic countries as well, because they recognise the generalisability of our data.
Yeah.
wow.
No, that's really important, isn't it? So other people can come and use your data as a sort of
So even
sample
though we're
for their research.
even though we're based in the north of England, we have we like to think we have international impact.
The global north.
Definitely.
The global north.
I like that.
Yeah,
That's very good.
You can tell we're from the north.
Yes. Quite biased. Yeah.
So could you tell us a bit more about why this project is needed? So obviously we do want to cure blood cancer if we can, and research into blood cancer is really important. But why is it important to have this kind of research rather than, obviously we have lots of clinical trials, but this is a bit different?
Yeah, I think it's so important that you can look at everyone because, as we've already said, patients that go into clinical trials by default of the eligibility criteria tend to be younger and fitter. So you're excluding a high proportion of patients potentially. And also, I mean, you could say more about the type of people who might take part in trials. So it's really important that we have population-based data rather than just those. And also, actually, what's really important to recognise, only about 5% of our patients go on a clinical trial.
Oh, wow.
There's
that's not much.
There's not many clinical trials. You sort of think there's always going to be a clinical trial for your disease, but actually, for the most part, most of the treatments are delivered out of a clinical trial.
Yeah. Well, I can imagine.
I didn't realise that.
Yeah, I suppose if it's a more rare cancer, you need a lot of people for a trial to have the power to actually get some results. So
and also these patients, as Debs has said, some of them will be treated for years. So you're not just looking at first-line chemotherapy, you're looking at those who then don't respond to the first line or subsequently relapse. So a lot of the trials are in the space of second line, third line, even fourth and fifth.
Yeah.
So some of our patients, myeloma patients, are on 7, they get 7 lines of treatment.
Oh, wow.
Right.
They're really complicated patient pathways. Just to say it, so HMRN, we set it up as obviously as a disease registry, but also as an infrastructure for research. So we do the routine data, we look at how many patients affected, how they're doing, and then we have add-on projects. So Debs has done quite a few projects looking at how patients are diagnosed and end-of-life care. And they're bolted on to the infrastructure of HMRN.
we have what's called a patient partnership. So we don't actually. We're not required to consent patients to take part in HMRN,
Right, okay.
but the ones that we can consent, we do try to.
Okay.
And that's because some people die soon after diagnosis, so we can't actually contact them. But because it's a population-based study, we need to have everyone in there.
Yeah.
So when we consent people, we ask them if they are willing to be approached again for further research purposes. And those that consent to that are considered part of our patient partnership. And that gives me a huge pool of thousands of people that I can go back to for qualitative research if I want to. And we already have information on them, so I can target them by age and their diagnosis and where they live and that kind of thing.
Yeah.
And so through that, and so I've been bolting on these kind of qualitative research projects ever since HMRN started. And my PhD, when Alex was looking at the epidemiology, I was looking at patient experiences of time to diagnosis and delayed diagnosis and symptom profiles, because blood cancers were known to have one of the worst delays in diagnosis across all the different cancers, particularly for myeloma. So we wanted to use our information that we collect in questionnaires, which we do as well, but also in patient interviews, to look at why that might be. Why does it take so long for blood cancers to be diagnosed? And we found things like, from the symptoms perspective, the common symptoms, for example, of myeloma are bone pain and fatigue, and the median age of diagnosis is 70. So people were going to see their GP saying, I feel really tired and my bones are really stiff. And obviously it gets confused with lots of, your age and, I was mowing the lawn yesterday or cutting the hedge. So, and that differed for the different diseases. So we were able to kind of understand that a lot better based on that. And then there was a lot of work about that we did on end of life care, because blood cancer patients don't have as much access to palliative care as people with other cancers.
Why's that?
Well, on the basis of the interviews with the patients and with interviews with the relatives of deceased patients and clinical staff, I think it's because they're often followed up for many, many years in haematology clinics. And so when it comes to their end-of-life care, they want to stay with this team that they've got to know so well, and who are actually quite used to providing end-of-life care for their patients. And sometimes they want to be in hospital as well, rather than at home, where they're looked after by these people who are all really sort of familiar
that they
to
know,
them.
and it's like their existing team, really, they want to stick with.
They've been there a long time. They get to know them, don't they?
They do, year after year, and they know their families and their neighbours and everything, whoever comes with them to the hospital, really. So we were able to put some more information about that, and then we looked at the chronic blood cancers as well, because the approach that we talked about is known as watch and wait. So it means that you've just been diagnosed, but you don't need treatment, but they observe you until you do need treatment. But for patients, you've just been told you've got chronic lymphocytic leukemia. You don't know how that's any different from acute leukemia. And patients think, right, I've been given this leukemia diagnosis, and where is my treatment? I want to start on treatment tomorrow. And they're just sent home and told to come back in 3 months for another blood test. So even though some people think it's great, I've only got chronic cancer, and others think, well, why am I not being treated? And they're really stressed, and they don't know what to tell their families. They don't know if they'll need treatment or when they'll actually need treatment, if ever. And some people compare that to Russian roulette, for example, so they really suffer from anxiety.
Yeah, we've actually looked at patients' quality of life. So part of how the patients get involved, they fill in EQ5D for us. And we've actually shown that patients on watch and wait have higher levels of anxiety compared to the normal population. So it's a real anxiety-inducing, isn't it?
Situation to be in, but yet they may have a normal life
Expectancy.
expectation.
Yeah.
So it's
Complicated.
So it's complicated, but it's really, really interesting.
It's interesting, yeah.
Because the patients, they have the lived experience, don't they? And they live with it day by day by day. So going to talk to them is really important. And I think some of the findings from the qualitative work lead on to more epidemiological studies and vice versa.
One of the studies we did was looking at chronic myeloid leukemia.
Right.
And at the beginning of the century, they developed a new drug called imatinib, which is a tyrosine kinase inhibitor. And it's one of the first targeted therapies. And before the introduction of imatinib, patients, unless they had a transplant, their prognosis was really, really poor. And basically, imatinib, the TKIs have totally changed the treatment landscape. That now patients with CML generally have a near normal life expectancy. They have to take the tablets every day.
But that would be instead of a transplant.
Exactly.
Well,
And
that's good,
I mean, we've got some patients in the registry who've been on TKIs for 20 years.
For the whole of the duration
the
registry that we still work with.
When we looked at survival, we looked at about socioeconomic status. So we looked at deprivation, area-based deprivation, so where a patient lived. And what we noticed was that people who are living in more deprived area, their survival actually was significantly worse compared to those who lived in more affluent areas.
Wow. Yeah.
So then we published that, and then Debs did a piece of qualitative work. One of our colleagues, Anne Hewison, did a qualitative work interviewing patients and clinicians around that.
So what we found was that although people take a tablet every day and it seems like nothing at all, the side effects from the medication included nausea was one of the key things, and so it seems like that not much to put up with really, but because these people survive so long, they're suffering with the side effects of the disease every day.
Every day for the rest. You think nausea,
I
can cope with that, but you don't want to feel sick every day.
So some of them would opt to, if for example they were going to a wedding or they had a special day out, they would decide that they weren't going to take their medication that day. And some of them didn't know how important it was to take their medication every single day as well, and they thought that missing the odd day was fine. So it's kind of the messages that are coming out of the hospital as well. But they also said that when they went to clinic, they saw people walking around with drip stands and no hair, and they thought that they were more deserving of the clinical time with the consultants and with the specialist nurses, and that their problem, that it wasn't worth talking about because they didn't want to take this time away from other people. But yet, when you actually dig into it, they were suffering these side effects every single day.
And if they don't take the tablets, they lose their response.
Oh, right.
Really?
So it's really important.
It's really important, So that's where the qualitative and the quantitative work come together.
Yeah, gosh, it sounds like a really, really detailed database. You've got all sorts of statistics and numbers and really detailed number data. But then the core work as well just adds a whole other layer to that.
It does.
And we respond to what the patients say as well. We had an open day back in, was it October 2023? Where over 100 patients and their families came to the University of York.
Oh, great.
And we had a day of talks and a lot of the clinicians came and we gave talks as researchers. And even though it was past COVID, a lot of the patients were still really concerned about COVID because these were the patients who had to shield. So a lot of them were still wearing masks. They were still avoiding going out into crowded spaces, weren't they? And it came up again during the day constantly about, they were worried about COVID. So what we did was looked at all the patients who was in the registry at the time of COVID started and they were alive, and we tracked them for 3 years to see what they died of. And for most patients, they didn't have an increased risk of dying for COVID. It was just certain subgroups which are well known because they tend to be more susceptible to infection and virus. So we could, in a way, even though everyone was past COVID, we could reassure patients that if you had your lymphoma, say 5 years ago, and you were treated, actually your risk of dying from COVID was no different to anyone else in the
Right,
population.
Mm.
So that's sometimes how we respond. You know,
Yeah.
you're saying, where does the research come from? Sometimes it is driven by the patients themselves as well as the clinicians.
Yeah. And that's really nice that you have those moments where you can feed back
Definitely.
to the patients that are in the database, so they don't just give you data and then
Not
you
at
forget
all.
about them.
No,
Yeah.
we have so we have our HMRN website, but we also have a patient-facing website.
Oh, great.
So we do lay summaries of the papers and have news items and help pages on there and
that's
things
good,
as
because
well.
That's really good.
Yeah, because there are a lot of people with blood cancers, isn't there?
Yeah, well, it's more than
It's the fifth most common cancer diagnosed in the UK.
Yeah.
And we help to run a support group as well in York. It's just York based because that's where we are, I suppose, really. But and it was based on patients who wanted to talk to other patients. But we have a monthly meeting with patients, and this is another linkage with the clinical network as well, because they give out the flyers for us, so newly diagnosed people can come along as well. And then we tell them about our work, but they can also talk to each other about their experiences. And I mean, some of these diagnoses are more rare than other ones, so they might never come into contact with someone, but actually they can come together there.
Because basically, with trials, there's always, when you're doing clinical trials, it's all about getting it into the real world, but you actually straight into the real world.
Definitely.
We are.
Definitely.
We are. And patients so we've been running the support group for 15 years now, maybe more, on a monthly basis, and sometimes we bring in other people from the university, or we'll bring in the clinical nurse specialists or other researchers, and it just makes patients feel that they're more sort of integrated with the system as well. And
that's great.
it actually means that they know about the work that's going on for them. So we've taken groups of patients to the diagnostic laboratories in Leeds as well.
Oh, great.
So they get to see how their specimens are managed. But it means that the staff in Leeds get to see, who are in laboratories with no windows, actually get to see the patients that they're helping as well.
So it kind of
that's nice.
It kind of works both ways. Yeah. So it's nice, and they help out other departments in the university as well. So
Oh, that's fantastic.
It is,
yeah. And so, what's next for the project? Am I right in thinking you've just had a bit of a funding boost?
Yeah, we're very lucky. So from the outset, Blood Cancer UK funded the project, and we were really lucky. And then Cancer Research UK started funding the project as well in 2020. And they have 5-year funding streams. So we just got our renewal, which started October 2025. So we've got our funding secured till 2030, which is really nice.
Oh, that's a lot.
And especially because a lot of the team, I mean, we've worked together for a long time, but there's other people on the team that we've worked with for over 20 years and 15 years. And it's so important to maintain that team because the data are really complex, and having that specialist skill, understanding the study, understanding the data, it can take people quite a while to get into it. So we're so lucky that we've got a brilliant team in ECSG.
And you got funding for another 5 years, so you're keeping the same people.
So we've got that sort of our core funding, and then we'll apply to other funding bodies to do particular projects as well. So
we've got a study coming up on CAR-T that's been funded by
on what? Sorry,
CAR-T. It's
it's a type of transplant, but it's using T cells, so it's a really new treatment.
Is that a blood transplant?
It's the T cell components of the blood.
It takes the patient's own cells and modifies them to fight the cancer.
Oh, wow.
It's really...
and then it's reinfused into the patient, but they often... you don't have CAR-T until you've already failed 1 or 2 lines of treatment.
Right, okay.
That's how it kind of started out. And it can have amazing effects, or it can have really severe effects on patients and their carers, actually, who are sort of looking after them when they're really at rock bottom and have a really hard situation. So we got some funding from NIHR Research for Patient Benefit, and that's to interview patients and their caregivers about their experiences of having this treatment, and also to follow them up in the longer term with specific questionnaires so that we can look at what happens to their quality of life their physical, mental health over time. So that's
and then
one.
to dovetail that, we're also part of the Leeds BRC and NHR BRC, which is the Biomedical
Research Centre.
Yeah.
Ah, right.
And
See why we work together.
We struggle with all the acronyms because we're also part of the Centre of Blood Research here at the University of York. So there's too many CBRs and
BRCs.
Acronyms.
Yeah, it's very lots of acronyms. And the NHR BRCs are really important for clinical translation. So Haematology joined that again about 5 years ago. So we work really closely with a lot of the academics at Leeds University and the clinicians in Leeds. And as part of the BRC, one of our PhD students who's based in Leeds but works with us here at York as well, is looking at the patients who got CAR T therapy, and he's looking at the biology of their tumours, of the tissue.
Right, okay, yeah.
So, and then how they do, looking at the side effects. So again, Debs is collecting about how the patients feel, but we can also then look at the biology and
so
how
you'll have
patients are
both sides
doing.
of it. Yeah. Fantastic. Oh, so you've got some good plans.
Yes, yeah, we've got a lot.
Great.
Yeah.
Because we've been going for 20 plus years now.
Yeah.
It takes that time for the data to mature, doesn't it? But
Yeah.
but also more and more people are aware of the study and want to collaborate with us, don't they? And the clinical staff around.
And I think what we try and do, because obviously people in the NHS are so overworked, and their priority is obviously the patients, we try and facilitate the research and really do things to help them so we can get the research out there. And so it's a really nice partnership.
And they can tell us clinical things that we don't know about as well.
Yeah.
So and sort of steer the things that we look at, and then we sort of conduct the research and feed it back.
So it's a real partnership.
It is. It's a good.
It's all a big collaboration.
Exactly.
Isn't it?
Yeah.
No, it sounds like you've got lots of great collaborations, and it can produce a really well-rounded sort of data set.
Well, data or information, research. Are there? I'm sorry, I'm going off piste again. So this is for blood cancer. Do you think that people are going to try and do this for other cancers, or?
I think the National Cancer Registration Service probably the other cancers were originally better ascertained and recorded. So the Cancer Registry is doing an amazing job, and they do a lot of research, and people access those data. So there is a lot of research going. But as I said, 20 years ago, the Cancer Registry data on haematological cancers wasn't very good.
I see.
But saying that, we're actually, we had a meeting yesterday. There's a big national project called Uncover, which has taken all the national haematology data. And we're talking about working more closely together, because obviously it's really important. They might not have the granularity of the data that we have, but they can identify patterns in the whole of England. And what we're going to do is that they're going to look at their data first, and then if we see any trends, we can then look at it in more detail in HMRN and hopefully explain it, because we've got more data to do those. So we work very closely with the National Cancer Registration Service as well, which is it's a really important service for the NHS England, and that you collect these data nationally as well.
It's an important
and also some of the sub-diagnoses, we only get 25 people in the region diagnosed with one a year, so we've got some really rare small numbers. But if we can work with the national data, they'll obviously have that a lot, even though it's still a rare disease, they'll have a lot more numbers, so we can perhaps do more research around that diagnosis than we can do.
But it must be very rewarding working in all this area. I've seen it come to fruition for 20 years and all this.
It's brilliant, because when we first went for funding, some people said we couldn't do it.
Oh, right. Well, look at you now.
Yeah, which is probably the worst, isn't it? Yeah, it's the worst thing to say to us. Because it is, it is really a lot. You'll know from trials, setting up a study, it's a lot of work, and you're relying on goodwill from a lot of people.
And especially people in the NHS who are absolutely strapped for time and cash anyway. So it's I think we've always held at the back of our minds all the patients that we come across in that time, and that's what's kind of driven us towards it, really, isn't it? Is to try and kind of get more known about these cancers and more accurate data for the benefit of patients and their carers and families.
It's it's not fair. Why should someone with chronic myeloid leukemia not have the research opportunity, say, breast cancer? You don't want to pitch against different cancers, but it's really important.
Yeah, definitely.
That this research is going on. For blood cancers.
Yeah. Wow, it's such a great project. And such a massive project. I feel like it's very impressive. You've got all this data and different kinds of data and data from all over the place. So it sounds really exciting. I'll be very interested to see all the great research that comes out of it. But yeah, I think it's maybe time for the hat.
Oh, I think so, yeah.
So I think we're going to do some random research questions now. So thank you for telling us all about your project. Yes, we're going to pick some questions out of the hat.
Okay.
What's your favourite part of your research?
My favourite part of the research is talking to patients and caregivers.
That's your job, isn't it?
Not talking to, but asking them questions and listening to them.
It's the same thing.
So, hearing their experiences just gives you such a different perspective. You can look at as many charts of patient pathways as you want, and we've got 55,000 of them if we wanted to 60,000, but actually hearing one person's lived experience in their own social setting with their own family and with their own friends and their own experience of their disease, it just it just paints such a different and clearer picture for me.
Definitely. I bet that's really rewarding and it really reminds you why you're doing it. Really.
It really does, yeah. And it never fails to give me ideas for new studies and thinking about where we can perhaps improve things for people who are struggling in certain areas.
Of course, giving you ideas,
it does. It does. And they'll tell you, they live with it every day, like I've said 100 times. So they know where where things could be improved and what could have been better for them, and what went well as well.
Yeah.
So that's mine.
So I'll do a more data answer.
I wonder why.
I think it's really nice when you've analysed the data, and for example, that myeloma story that you said, which actually made the national press, showing that things have improved for patients over the last 20 years. To say that their median survivals has doubled is so positive, to have actually some positive news.
Yeah, definitely.
Because sometimes when you're looking at the data, you think, survival can be really poor, or patients can have a really bad experience. So to actually say something positive was really nice, and I think showing the impact of the work, not just to patients as well, to other stakeholders and to clinicians.
Yeah. What was your dream job as a kid before you knew that researcher was an option?
So, as an epidemiologist, I'm going to sound really morbid here, but I've always been interested in why people die. And I think I've always had a strong interest in. Well, it sounds really weird. So I've, and then when just really interesting that how people do and things like that. And then when I did my undergrad, I did biomedical science. We actually had a module in epidemiology, which I didn't know existed until I did then.
Okay.
And then I realised that I definitely didn't want to be in a laboratory.
Yeah,
I like the patient aspect. I like Deb says, you sort of see the stories in the data as well.
Yeah.
So I really enjoy that sort of aspect, and then looking at how patients are treated, how patients do. So I think I've always had an interest in doing research.
Yeah, it sounds like this is your dream job.
Your job.
Fantastic.
Oh, I've had quite a few dream jobs already. Yeah. So when I was younger, I wanted to be a missionary.
Really?
I don't know why. Because I'm not particularly religious. But I do like travelling.
Yeah.
You just thought, I want to travel and be a missionary.
Yeah, just want to go to some exciting places.
I don't know which one's worse, me or you.
But I was lucky enough to be an anthropologist for a while in Mozambique.
Oh, wow.
So I did a lot of traveling around there and sort of camping on farmsteads and talking to farmers and things in the middle of nowhere and dodging landmines.
Wow.
Which was probably what put me off. And then getting malaria and thinking,
oh, gosh.
Home comforts might be quite nice.
Yeah.
And then I met Alex, so...
Yeah.
Yeah, I think sometimes life's better when you just fall into it rather than planning, because you don't know what opportunities are going to come, and
definitely.
You fell into epidemiology.
Yeah, I then did a master's and then went to Leeds to do my PhD.
Yeah.
And what actually got me into blood cancers is that for my master's project, and this was using the National Cancer Registration data, is that patients who've got chemotherapy, say for breast cancer, some of them actually then get leukemia because the chemotherapy causes. So that's what I did for my dissertation, and it really fascinated me. It just felt awful that you were being treated for a cancer, which then
led to
a very small
one.
proportion of patients may get a different cancer.
Yeah.
So, and I think back then a lot of the work was around trying to prevention etiology that way.
Yeah.
So that's how I got interested in blood cancers.
Yeah.
And then I was really lucky that Blood Cancer UK funded my PhD and then a lot of my career. So I've been very...
Blood Cancer UK.
So just a shout out to the cancer charities and all the people who raise money.
Yeah.
It really makes a massive contribution to research.
Yeah.
And sometimes they'll do projects that other funders won't do because, again, it's driven by what the patients want.
Yeah.
So we're very, very lucky to have charity funding.
Yeah.
We are, particularly at the moment.
Yeah.
What's the most unexpected or surprising thing you've discovered so far in your research?
In some of my patient interviews, when I ask people, what do you know about blood cancer? They don't know anything about it. And they've been diagnosed perhaps with myeloma and they thought they had a melanoma.
Right.
Oh, no.
Yeah, so I think the lack of understanding and knowledge about blood cancer is kind of a real surprise. And they'll say, I've maybe heard of leukemia, but lymphoma, what's that? So they have all kinds of words that they use for like lymphomatoma, or the words that they hear and they've kind of made up almost. But that sort of lack of understanding in this day and age of cancers that are, after all, quite common is quite surprising.
Yeah, definitely.
Yeah. And going back to the descriptive epidemiology again, I think one of the surprising things is that men are more likely to be diagnosed with a haematological cancer than women.
Oh, really?
Yeah.
So there's not many. So unlike other cancers where, we know smoking increases your risk, obesity, there's not many lifestyle factors that contribute to development of haematological cancer. But one of the biggest risk factors, apart from increasing age, is being male. So again, that really drives towards the biology of the diseases.
Yeah, and that's something you could pick out from the data that you might not
so
know.
some of the subtypes, such as Burkitt lymphoma, the rate is 5 times greater in men than women. So it's not, it can be.
So then you can go back and think, why
and
is
that
this
is the big question. Why is there such a difference? And I think if we solve that, we'd win the Nobel Prize.
I'm rooting for you.
We talk about it with our colleagues in biology, David Kenny and Hitchcock and Adele Fielding. That would be the question we'd all like to answer.
Crack it. Come on,
you come on if you get your
when you get your Nobel Prize, you want to come back to us.
Would you'd come back?
Oh yeah. As an epidemiologist, I'd never get a Nobel Prize. It's the people in the labs who do the exciting discovery. We're like the background staff. Backroom staff.
Very important.
Yeah. Essential anyway.
Yeah,
definitely.
Yeah. Well, I mean, epidemiology often is generating hypothesis. So you're looking at the data, you're looking at the patterns, and that, for example, is like, why are men, we see an increased risk for men.
Yeah.
And then I think that's the thing about cancer research. It's really multidisciplinary. You can't answer a question with one speciality.
No.
You need all the different specialities being involved.
Yeah. What's one thing you wish you knew earlier in your research?
It's a challenging field to work in. Yeah. And I think that's one of the key things, and it's very. I think you don't always know that before you come into it, and it takes a long time to get funding, because I think only one in 5 projects, or there's 20% chance of being funded.
Funding,
so you write a lot of proposals that you then just put on a pile in the corner. Steadily grows, but it takes a long time to do that, and then the process is quite slow of having to go through ethics and get everything approved, and then get things set up, and then get your study actually running. So I think sometimes working within those boundaries, when you actually, what you want to do is just get out there and start talking to people. I think is one of the challenges that I face.
I think my challenge is that the older I'm getting, I realise at least I know hardly anything. You sort of, because you really, you think you understand something, and then you talk to someone else, you think, oh wow, I had no idea. So I think it's always having to accept that you don't know everything, and actually, and sometimes you have to do things a different way, and things aren't set in stone, especially in, I think, observational studies, because there's a lot of variation you can't control. So I think it's sort of just been quite relaxed and going along with the flow, and just realising I think now a lot more is understood about haematological cancers. You realise there's just so much more still to understand.
It's like the more you discover, the more you find out you don't know, and then you need to do more research, isn't it?
That's what Paul Weller said.
Oh, really?
Yeah. The more you know, the less you understand.
Yes. True.
You've got the soundtrack.
Yeah.
I don't even know how it goes.
Yeah.
There you go.
Sure, we didn't have that question, did we?
Soundtrack.
That's the theme song for this one. Definitely.
Yeah. So you do have to have an open mind, don't you?
Yeah, and I mean, and also that you've got to be able to work with other people. There's no point being a brilliant researcher if you're not a team player.
And you've got to be curious, haven't you?
Yeah.
And
you're doing it for the love of the. I mean, obviously, you can tell that we're
enthusiastic.
And you can tell when someone's perhaps not, bothered that they're actually looking for cancer, or they're just doing it. You really do want to know about your topic and want to find out.
Yeah, because the pathways are so different for those diseases that you need to be curious enough to understand what they are before you can go ahead with your research, really. Otherwise your questions might be meaningless.
You're right.
So
what's the nerdiest thing you do?
I
can answer on Alex's behalf.
I look straight at you. I don't know why.
Yeah, Debs feels that she's all her colleagues are absolute nerds. You better stop me after 5 minutes. Yeah.
But, so I sit in the office with my office door open, and we're in an open plan outside. And there's quite a lot of members of the team that gather together to talk about what their favourite data command is.
Oh,
no.
Yeah, that is nerdy.
That's nerdy, isn't it?
Definitely.
So
I can see the data people being a bit.
Yeah.
So
I'm
unanimously
known as the most interesting person on the team.
You've assigned yourself that title.
You must have nerdy things that you do.
You're in research. There must be something.
We're all nerds.
Yeah, so I'm a qualitative researcher, and I've been lost in an in vivo, an analytical hole before of coding. So,
coding, right?
Yeah.
Coding all the interviews.
Yeah, of my interviews, and then you code it, and then you break it down, and eventually it's meaningless, and you realise that you've fallen down a hole.
Oh yeah, that's quite nerdy. That's almost as nerdy as sort of being interested in the data, I think.
I think it's just
I think she fights it, but she just accepts.
You can't resist the
You're part of a epidemiology and cancer stats group. You're a nerd.
Yeah, the nerdiness is, I've absorbed it over time, I think.
And Alex, you're just...
I accept it, yeah. I'm not ashamed.
Good. No, it's nothing to
and
be
I do say to
ashamed
Debs, we couldn't answer her research questions without being nerds.
Yeah.
She needs us.
I do. Yeah. We're symbiotic.
Yeah, we do. Yeah,
symbiotic nerds.
Yeah, because she does the qual, and we do the quant. So it's yeah.
Oh, fantastic! Oh, well, thank you so much for talking to us today. That was really, really interesting, and it's a really fantastic project. And, thank you so much for coming in. We'll put some information in the episode description with maybe some links, to the website.
Yeah, to the website. Yeah,
definitely. You can have a look at
all the papers,
and
the data,
and papers and things. Yes, we'll put some links in there if you want to find out more.
Right.
But yeah, thank you so
much.
Thank you for coming. It's been brilliant.
Thanks.
Thank you.
Don't forget to like and follow The Research Room wherever you get your podcasts. And if you'd like to leave us a review, that really helps other people find the podcast.
Does it?
It does, yeah.